Well, what a delight it is to be here today. You folks are doing some wonderful things, and I am delighted and honored to be invited to participate in your learning experience and to learn with you. My career began at a time of great change in healthcare. When I first graduated from high school, my first job was with Southern Pacific Railroad. And in order for me to go to work there, I needed to go to the Southern Pacific Hospital to have my exam. And that hospital had been in Houston, Texas for some 40 years then. It had started as a way for those folks who worked on the railroad to have access to care. And a lot of them were in that hospital for weeks and months on end. It was phasing down by the time I got there. When I entered healthcare and graduated from med school was just as the St. Jude's Hospital had discovered ways to change childhood leukemia survival from 3 months to more than 50% with 5-year survival. This was such an exciting thing, and that's why I went into pediatric hematology-oncology, largely because it was such great promise. We used checklists. We had flow sheets on every child. Every child was entered into study. I was in Northern California and working with Stanford and UC San Francisco and UC Davis. It was a great experience, even though I was physically working for the Air Force. I was one of 2 pediatric hematologist-oncologists for the Air Force worldwide. I took care of western U.S. and the Pacific, and Fred took care of central and eastern U.S. and the Atlantic catchment areas. Things changed a lot, and it has been an extremely saddening event for me personally to see how healthcare has deteriorated on my watch. Folks, we're behind Slovenia. Think about that. We are behind Slovenia. We're ranked number 38. And it's not because we don't have the tools, the capabilities to do things right, because there are many examples. When I was at Headquarters Air Force in Europe, we worked with all of those countries there, and none of them organized and delivered care the way we do it in the U.S. It was a really enlightening experience to me. And once I got into the private world and realized what difference there was in the way things were going on in the pediatric hematology-oncology world and the military world compared to what was going on the, quote, outside, I truly was shocked. It was real culture shock for me. What I'd like to talk with you about today are some promising events that are happening. I'm so delighted with what Atul was talking with us about in regards to changing and transforming care and safety in surgical practice and in hospital settings. I'm going to talk with you about applying these same care team principles with aligned incentives in the population health, the primary care, and the ambulatory care arena. It's kind of the rest of medicine. Pediatric hematology-oncology is mostly an outpatient practice. It's very intense and personal. The relationships with those kids and families, they become part of my family, and I became part of their family. And that's the model that I come from and the experience that I've had. So pardon me if my perspectives are colored compared to what you may be seeing around elsewhere, because that's just the world that I've lived, and that's what I expect things to be. And so I keep trying to clone those things that I've seen work as opposed to reacting to those things that do not work. So our objectives today are going to really be identify some of the root causes of our healthcare system failures, describe some team-based interventions both at the population or community level and at the clinic and the patient level that are working and sustaining health improvements. We have now 4 years or so experience of this being sustained. Define lessons learned and critical success factors that are from this self-rate us in the audience today as to how ready are we, the people in this room, to drive change, and how would we drive it. So those are the goals today, to see what are the next steps we can and must do together. Now, the cost and quality drivers that have gotten us where we are, the ones on the left are mostly geopolitical, and probably you and I individually cannot dramatically impact each one of those. The normal inflation rates, the worker shortages, new technologies that are usually very overpriced in the US compared to what they are if they are birthed in other countries, et cetera. And the fact that our population is aging in place, and therefore there is a medical cost trend that continues despite everybody's best efforts that may not be that changeable. But there is a lot that are based on our choices that we make that are on that right-hand column. And those really relate not only to patient choices and consumer choices, but also to doctor choices and hospital choices and healthcare provider choices. Many of those are colored by the perverse incentives that apply, so a lot of my emphasis will be not only on financial incentives, but on non-financial incentives that have to do with connecting people, connecting caring people with folks who have needs, and connecting those who have the resources to provide for those needs with those people who have those needs. And many of these things we in healthcare are not leveraging. We are not actively participating in addressing the social determinants and the environmental determinants of health. And they turn out to be very much more successful for both them and for us if we married our efforts more intently. Now, all of you know that both the number of people and the percent of people in our beneficiary populations and in those we serve have chronic conditions, and increasing numbers of chronic conditions, and increasing burden of those chronic conditions on their life and their livelihoods, and their success and their vitality. There are certain things that are actively contributing to that, one of which is obesity. We have a particular knack for how we are accumulating the adiposity in our environment. And we're doing that at more rapid clips, although unfortunately those who are trying to copy us at improving their economic situation are also copying us on the bad habits we have that are contributing to this epidemic. And so this is now becoming a worldwide epidemic. We have focused our energies to date on rescue care. Every system is perfectly designed for the results it gets. This situation in America, part of the reason that I was so attracted to the world that I live, the pediatric hematology oncology world, was there was such promise of rescuing these kids that had cancer. And I saw some incredible events during my career of real success and real change that was rescuing kids who didn't deserve to be in that situation, and bringing them through to healthier status and long lives. That's extremely gratifying. In the same way, we have taken heart disease and, starting with Michael DeBakey and others, have done remarkable advances in rescue once somebody has a heart attack and making it so they are living much longer. We're not doing so well at preventing the heart attack in the first place. And we are not doing so well at how well our population is as they perceive it. Well-being is really not purely the medical burden of illness that you have. In other words, well-being is not the absence of disease. Well-being is much more. And we are failing in most states. In South Carolina, you can see from the map there, you're in the 4th quintile. It's interesting, the states that are the green, that are in the best quintiles, are places you probably don't think of as world meccas for healthcare, like North Dakota and places like that. But their well-being, as you measure it by people feeling like they have a purpose and they are motivated and activated to accomplish their goals, they have supportive relationships and love their life and what's happening with it. They have love in their lives. They feel like they've got more control of their financial situation, and don't feel as burdened with the threats of financial instability. They feel like they live in a community where everybody works together and helps each other. When you get down south, it doesn't work out so well. And I didn't even mention the physical. And we know that our burden of illness levels in the Deep South are not meeting muster. We're not doing well. So we have challenges that we can and must address for our country to remain globally competitive, that really include a lot more, as we've talked about earlier today, than purely the physical rescue of someone who's had a catastrophe, whether it's induced with injury or it is induced with some disease that is either based on their choices or based on their genetics. You can see the impact that our behaviors and choices are measured in one aspect of how people choose to receive care. It turns out, and this is in Massachusetts, which is probably a lot better than it is in Nevada, only 38% of those folks who are showing up to emergency departments need to be there. There really are other options that are better. That's a 60% failure rate. The rest of the system is not accommodating their needs. Some of that is because of the incentives. If somebody else is paying, only the best will do. And if we are talking about emergency care, you can see that it is extremely expensive. It's about $1,000 more per visit. And when you multiply that times the visits that are avoidable and unnecessary, that comes out to be a big chunk of change that we probably could deploy in other ways that would create much more well-being than what we are frittering away here. I recently had a situation where we were having a patient-centered medical home conference and discussion, and Paul Grundy from IBM was visiting Las Vegas and was having conversations with large employers and provider groups. And what he noticed was that as he drove from the airport to the place of our meeting, which is only about 3 or 4 miles away, that he passed 4 signs on the freeway that said, ER wait time, 12 minutes, text here. His comment to us was, folks, if you ever dreamed that IBM would ever open a facility in Nevada, you just lost that shot. There is no way, if that is what your value system is, and that's what your priorities are, and that's what you advertise, that we're going to be moving any of our manufacturing or our people to Nevada as a base of operations. So these things do influence real financial decisions that have real impact. You may not have noticed, but Nevada has had a very severe recession. It's very hard for me to tell the difference when I listen to my parents and before my grandparents talking about the Depression. I got to tell you, I'm not sure that the Depression was that much worse than what we've experienced in Nevada with this recession. This has been really, really, really serious. So we're beginning to have some recovery now, but we are not on stable ground yet. And necessity is the mother of invention. Some of these principles and ideas that I'm going to present to you really are because of that recession and that catastrophe that happened that forced employers who had had very long-term relationships with their employees who were as if they were their family members, who suddenly had to dramatically change the way the ship was driving and where it was going. And so we'll explore some of those lessons learned and what impacts that's had. But when you align the incentives of the system such that the individual makes the decisions that are in their own best interest, you can't really blame somebody for going to the ER to get their struggles or their inconveniences addressed. It's open 24 hours a day. They can't turn you away. It's federal law, you can't turn them away. Everything is there. By the time you leave, you will get your answers. What's not to like? Especially if somebody else is paying for it. And for Medicaid, it is zero out-of-pocket expense to do that, and probably that way in many, many states. So why wouldn't they do that? We can apply the same principle to doctor behavior in our system. This is work that when I was at the Culinary Fund, the Hotel or Restaurant Workers Union Health Plan in Nevada. It's a larger plan, about 125,000 lives at that time, and we contracted with physicians of multiple specialties, and we analyzed the patterns of care. We've talked earlier about the differences and the variations in these patterns of care. And what we did is we said for those doctors in a specialty who saw more than 30 patient events of common kinds of things like ear infections, urinary tract infections, knee surgeries, etc., what was the most expensive provider that got the same result as the least expensive provider? How did they compare? What was the pattern of care that they did in their delivery of care for more than 30 patients for each of these episodes? The most expensive family practitioner was about 9 times as expensive as the least. For the earache, that the earache went away, they treated it, there was no more ear pain, the earache's gone. Outcomes were the same, the expense was 10 times as much. Same thing for bronchitis, about 8 to 10 times as much for a bronchitis episode. It wasn't focused just on family practice, the internist got in the game too. So for urinary tract infections, again, about 10 times as much for the most expensive compared to the least expensive. Not 10%, 10 times. For knee surgery, again, a huge multiple and a whole lot more dollars for the most expensive versus the least, and all, so far as we could tell, were able to walk with their knee replacement after it was done. So we really couldn't tell anything from the value measure of whether the function improved between those that were the highest and the lowest. Can we really afford that? Is that really something that we can sustain? You can see the impacts of these choices and these incentives on the healthcare cost trends. As you look at this, the yellow is the consumer price index. So that's sort of the baseline inflation rate that has to do with those things that were on the left column as I was showing you the cost and quality drivers in that early slide. You can see that the blue line, which is the total of healthcare trend after the plan and contribution changes, so after you adjust for the actuarial difference between various plans, so you get them all indexed to one comparable measure, that it typically is about twice the rate, and often has been higher than that, of consumer price index inflation. But this new one, that's the blue line up here, the discrepancy between that and the bars below is how much the patients are having to bear of this now. So what the people that have been paying the bills have discovered is if you shed more of that to the patient for them to pay for it, you, the plan sponsor, don't have to spend quite as much as you would otherwise have to spend, and maybe that will engage those members at thinking twice about whether we really do these things. Unfortunately, the information to make the informed decision about those choices doesn't usually go along for the ride for these people. So when these folks that are in the consumer-directed health plans or the high-deductible health plans or the cost-share health plans are not usually getting transparent performance and cost information in order to make informed decisions about how to spend that money that's coming out of their own pocket now. So we have these consequences that are beginning to affect millions and millions of Americans. And it's impacting, you can see that it's not changing the prevalence and the ramp up of our chronic disease and our burden of illness, and it's not solving our problems about well-being index and getting our health better. Now, 82 of the largest employers, so the votes are in on the large employers for what they think. This is members of the National Business Group on Health. What they think are the most effective steps to be taken to control these trends in healthcare cost. And perhaps not totally surprisingly, the one at the top is just make it so that the folks that are in the plan pay more of the bill, consumer directed. And actually, if you make it so you increase the employee cost sharing, you add those together, they beat everything else as regards. They kind of would rather just wash their hands of it when you get them to put their votes down in writing, because it's really, it's too much. There are, in the second tier there, a group that believe if we could get our people more healthy and with better functionality and well-being, if you can get people healthy, then the cost of illness is less because they're not ill. So it makes sense to emphasize this, but how much teeth are being put into those measures to get patients and consumers engaged in taking ownership and moving from the passenger seat to the driver's seat are highly variable. There's a great willingness to give away and to reward for filling out forms and getting tests. And it gets a little more dicey as to whether there are any consequences if you don't do that or you don't follow through with any of the behaviors that one might expect if you saw all these bad things on your report card. And then it scales down dramatically in regards to the interventions they believe are most important to do and when you get down to care management and utilization management and high performance networks and those kinds of things are less popular and voted less frequently on by the large decision makers that drive much of healthcare decisions in America. Now, I mentioned that a lot of them would like to just bow out of this equation, and I think many were hoping that the Affordable Care Act would make it so they could say, okay, look, I'll just pay my fine, y'all go over there, good luck, hope it all works out for you. But then when they actually started looking under the hood of how much it would cost the employer sponsor to abdicate the throne and turn it over to health insurance exchanges that they believed at the time might actually work and deliver what was promised. Now it turns out it actually is more expensive when you do the ramp up of the salary in order for the employees to believe that they still have the things that they had before. So it turns out it actually adds expense rather than reducing expense, and you really haven't gotten out of the fray after all. And so it really became a conundrum that's a tough slog. And we were talking earlier today about the fact that what we know is care is going to change. What we don't know is what it's going to change to. And so there's a lot of instability and lots of wondering and lots of hand-wringing and not very many clear directions of what happens next. Who will drive that change? Who will be the people that will make something happen? I would postulate that if you follow the money, you can probably figure out who is going to drive the change. Right now in America, the employers pay for about 55% of the health coverage. Individuals pay about 10%. Government programs like Medicare, Medicaid, and the TRICARE program for the military represent about a third of the spend. The employers, which includes the federal employees, the federal employees are not on Medicare or Medicaid. They're on an employer-sponsored plan too. The municipalities and the state government's employees are in this bucket that's up here in the top that is employers. So those folks that are writing those checks appear the most likely to have the most skin in the game to drive change because they're committed. You know, it's like the story of he who is committed versus those who are promising. These folks are committed because they're going to be bearing the cost, and they are trying to compete now globally. And the BMW president and the Michelin president will say, "You guys fix this. We don't have this in France and Germany. Why are you doing this?" So they're needing to compete with these other forces that are going on globally, and they have global workforces, and they're not experiencing this in their other countries. And you can see the handwriting on the wall as to what that likely implies to be future behaviors and future choices of those who are bearing these costs. The government has skin in this game too. I mentioned the third. And right now, total government spending, this includes both state and federal government spending in the U.S., by far the largest bucket is for health care. It's much more than the military, it's more than education, it's more than the other social services, it's more than pensions, it's more than Social Security. So we've got a challenge. They see the challenge, and they're starting to do things. Here's what CMS is doing, and I know this is a busy slide, and I needed to get this so you could kind of see the sequence. But essentially, the sequence is that there are 3 federal laws that have been passed in the past few years, starting in 2006, that drove physician quality reporting. And so that first, the light blue color there over on the right are these approaches that drive the reporting of performance. Then when you get down to the elements at the bottom, it's really the consequences of those measures of performance so that payments are changing as you get further down the scale. So that if you're not delivering high performance with quality and cost value combination, then you get takeaways from your payments. And so they have those that were at that bottom third in that prior slide that are this group down here, the Medicare, Medicaid, and military are saying, buck up, bud, deliver better, or we'll pay you less. And the question is whether the rest of the employers are going to follow this, or the states for their own employees going to, or maybe they are already following this. The consumers, as they're bearing 20 to 30% of the bill, are they going to demand this? The baby boom generation are a very demanding generation. They tend to expect and get what they want. So one can see that as they are in more and more of that cost-bearing part, that demands are coming and stuff does need to change. Are the providers accommodating to this? Not just the health systems, the big hospital systems, but also the rank and file docs that are in the offices and office practices. Now, at a state level, there are, or really even at the national level, there are teams that are beginning to drive value by starting at the baseline with cost and quality transparency, where they're actually displaying the relative cost for Joe versus Susie versus Mary, and the outcome, so that it's the performance combined with the price, so that people can see the comparisons. And a lot of times the brand name places don't perform any better and may actually perform worse than the places that Johnny also rans in that are in their state or in their community, but where the results actually are superior. And this includes places like Mayo Clinic and MD Anderson and places like this that have had a great marketing campaign and generated lots of funding, but when it cuts to the chase, to the actual performance and outcomes, they don't always star, and that drives change. The employers can be driving this and expecting it in the contracts that they have with their providers. The consumers, as they are bearing more of the bill, start demanding more improvement in health care outcomes for the amount of money they're spending. And the providers themselves, many times, are the largest employers in town, and they themselves are bearing the brunt of these costs. If you looked at 350 or 400 communities across the U.S., starting from the largest coming down to the top 350 or 400, you would find that in most towns, the hospital systems are the biggest employers. So they're bearing the brunt of this up close and personal, and they actually have tools and options to test models to improve care delivery and efficiency on their own folks and save money for their own operation that they may be able to deploy to other more beneficial resources and activities. So at the end of the day, those things that drive value are aligning the financial and non-financial incentives. The non-financial incentives I'm talking about here are relationships. They're social relationships where you are meeting an unmet well-being need that has to do with these other elements that are not purely the medical element. You're also building trust and building sense of community and coordination and setting of mutual goals that we can commit to. And I'll give you some examples of this in a model that we're testing in Nevada and Southern California. The other is that the actual performance, the actual outcomes of both the patients and the providers needs to be conspicuous. It needs to be conspicuous to the doc when the patient doesn't do what it is she said she was going to do, and it needs to be conspicuous to the patient when the doc doesn't do what he or she said she was going to do. Somebody has to be the scorekeeper and keep up with what's happening here. And it needs to be communicated in a way that actions can be taken. The next is that, especially for the members and the consumers, We have been beating up on hospitals and health plans and doctors and delivery provider systems for decades now. We are not doing anything very much about getting the attention of the consumers. The only person that has continuity with Mrs. Jones is Mrs. Jones. She is the only person who knows what's happening with her. And if she is demented or she has some other challenge, it's only her guardian or caregiver who really knows the story, much like Atul's story earlier about the Cheesecake Factory leader whose mother was suffering the adverse consequences of our current broken delivery system. That person knows what's really happening with Mama. And we need more than just for Mama and or her caregiver to know what's really happening. And we need them to feel empowered, capable, and confident enough that they can actually speak up and make things happen that need to happen. And so really we need to move the consumer or the member or the end user from the passenger seat to the driver's seat. And the rest of us support that driver at getting that car where it's intended to go. So really, there are patient activation measures now that really scientifically, validly assess how activated a patient is as to their confidence, their will, their capability to accomplish and take charge of their own health. Less than 40% of Americans meet muster for being activated. They believe that's somebody else's problem. My health is somebody else's problem. Take care of it. Well, it turns out all of those others are visiting firemen. They might do something for today, but it ain't going to change the long-term story for Mama. So we have to be able to assist these folks with getting more engaged, and we need not just the care setting to be doing this, but we need the environment, the rest of the story. It's the surround sound experience for these nudges to make it easier for Mama to make the right choices rather than saying you ought to go stop smoking. The directing doesn't work. It doesn't change any behaviors or outcomes. So there are a variety of delivery models that are focusing on this better primary care approach. And they can be on-site clinics, as I mentioned, with Southern Pacific Hospital, or many employers now have their on-site clinics, or near-site clinics and pharmacies. Some are having mobile vans that take the care to the people on these big campuses. Intel has a campus that has mobile vans that take the care to the work settings. Retail clinics and pharmacies, telehealth in rural settings especially, emergency care, immediate care, rented networks, but really something that is continuity care is still not happening very much, and continuity care that is connected to the rest of the story is not happening very much. So I want to give you a quick view of a model that is focusing on connected, coordinated community, connected, coordinated, and continuity care. It involves care teams with the patient at the top. Depending on if the patient is totally enabled, the patient runs the show and they may not need anybody else. If they're really taking care of themselves, they just go in when there's something that's needed. But that's not the case with most Americans. And so most need other help, and they don't need just attending physicians, but usually attending physicians are their most trusted ally if they have access to one on a continuing basis. And the rest will be most trusted for particular domains. So this care team approach is expected to deliver better cost, better quality, and better satisfaction, and I'll tell you the model. In this one, this is a system where self-insured employers offer a plan and a benefit design that contracts with high-performing primary care centers, or PCPs, to deliver high-performance requirements that are in both the safety and quality, the satisfaction that's measured with every visit, and the cost showing that the resources are going down, and they only get their bonus if all of those three are hit. It is supported by a care team that can be at the work site or in the union hall with coaches that are right there. It may be more commonly with telephonic coaches that are an extension of that primary care office. And they are then looking at this care support from enabling the patient to accomplish her care goals and her care plan, so that when she sees her PCP, she enrolls and chooses a care plan, which is basically see your doctor, get your test, go to the referrals when you're sent there, come back. It's not really highfalutin stuff. It's basic blocking and tackling. But it involves also a tracking, reporting, and accountability system that keeps up with whether the docs are doing what they said they would do, whether the patient is doing what she said she would do, and whether the coach is doing what she said she would do at supporting these goals. So it's really a system. And typically, the self-insured employer offers two plans. One is this preferred plan with this system, and it's more rich benefits with concierge-level service at the doctor office, same-day fit-ins, cell phone answered within 3 rings, called back within 30 minutes if not answered within 3 rings, satisfaction after each visit, confirming that all of those standards were met, and then measuring the quality metrics and the cost metrics. Our responsibilities are the glue holding these things together with the information system support, the care team support with the coaches and that sort of thing if the doc doesn't have that already, and the feedback to both the docs and the patients as to where they are on their care plan that they promised they were going to follow. The registry turns out to be a glue that holds this together. It's an online web registry that the docs enter the information at the end of each day as to what they did with those patients enrolled in this plan that day. Turns out they mostly are using a one-page sheet of paper that has the screenshot of the key elements of what they were there for, what they did, what their decisions were, for their staff to enter into this web-based registry. They have a variety of different electronic records, but they are variable, and most electronic records today don't have decent registries, so they use this one in order to get everything consolidated into one master plan. And then the rest of the feeds feed that registry so that you can get the rest of the story from the claims, both the pharmacy and the medical claims, the lab results, et cetera, to know what's really happening, and then that activates the feedback as to how things are going. When the coaches, the PCP, and the medical claims data comes into the registry, that then bumps up against these adherence guidelines as to whether the care plan is being followed and accomplished. And they get the rewards if they're being accomplished. They get the reminders if they're not. The system is typically the first strike is a warning letter. The second strike is financial consequence. The third strike is you go to the other freedom of choice plan because you really don't want to do the plan stuff. So we've had the experience is that 17% get their first ding, 1.7% get their second, and only 1 out of 700 got to the third ding, and that was in the 12th month of the program. So people get it, they understand it, and they carry on with stuff that's kind of common sense behaviors, but it's a supported system with accountability. The health coaches include RNs that are experienced disease managers. They follow them into the hospital and so forth too if they are admitted there to make sure that the continuity and the transitions of care work smoothly. But they are mostly encountering the patients with direct discussions and setting goals that are the patient's goals, the goals that the patient sets, not the ones that the doctor or the coach sets. So this is really assuring that what the patient says that she's ready to do within the next month is what's prioritized. It's not what we think is the most important that she ought to want to do. It's not our call, it's her call. Now, we use in Nevada, HealthInsight is managing a health information exchange that is statewide that connects the electronic health records of the hospitals, the imaging centers, the diagnostic testing centers, the doctor offices, both the specialists and the primary care, and more of the rest of this continuum. So this system can also ping that system to see the rest of the places mama goes, what happened when she was at the hospital, what was the discharge plan, did they change any diagnosis, change any meds, and that kind of thing. She is supposed to call the doc, her PCP, within 72 hours after discharge to say what happened, but this is a backup system that helps supplement that continuity and connectivity. The plan sponsor has to be willing to blink, has to be willing to say, I'm going to take a chance on this and offer a plan that has expectations that folks can meet. And not everybody's ready to do that. There are still plenty of folks that are giving very rich benefits and playing like this is not a big deal. So not everybody is ready to do this. But when you do it, it really is remarkable the impact that this can have. What's in it for the plan sponsor is cost savings, quality improvements, and I'll show these results, and patient satisfaction improvements, because many of these have had patients that are going into their HR office frequently complaining about the nature of the service levels that they're receiving in the healthcare system. The patient has to be willing to stick with a care plan. You know, it's pretty basic stuff, but they need to say, yes, I agree to stick with a PCP. They can change, but it turns out that only less than 2% of them actually change to a different PCP. Sometimes people just don't hit it off with the one they originally chose, but most of the time it works out. They get much richer concierge-level service and much richer coverage. So what's in it for them is they can get in the same day if they have an acute care need. They get their answers fast. They're in and out within 60 minutes. And so really their need to go to the ER is much less because they can get in. And then the providers have to meet this of fitting people in and seeing them that day if they're called by 10 a.m., having them in and out within 60 minutes unless it's a chronic condition and both patient and doc agree this is too much to be done in 60 minutes. And then they meet the satisfaction levels for that. They will receive their bonus, and it's a substantial bonus. It's a 50%, a 50% bonus for these primary cares if they hit all three. 85% satisfaction, 85% quality metrics hitting the targets, and 15% savings from the baseline actuarial expectations. And you'll see that they hit it, and they've hit it every 6-month period since we started 4 years ago. Every one of the docs have gotten the bonus every single time. So they get better pay. They also get publicity and recognition. This shows the trends in cost, what was actuarially expected over a 2-year period, since the baseline trend in our market is around 8.1%. When you run that out actuarially for 2 years, that comes out to be about an expected 16% increase over that 2 years. And what happened is the actual costs were 29% lower than that actuarial expectation. And at 2 years, the total per member per month cost was 17% below what it was in the baseline year before we started. And these folks have aged in place 2 years. This particular model took the 1,100 who were enrolled the full 12 months at the end of in the 2-year measure period, and looked back at the member months, how many member years were in that same group at the beginning. So these are the same people, the same humans that are being measured at baseline versus the intervention period. Not unexpectedly, the things that went down were those things that you think are largely lower value services that have less impact on total health outcomes like less inpatient admissions, less ER visits, less bed days, less procedures, less images, but more office visits, encounters. Prescriptions per person stayed about flat. Cost of prescriptions went down because there were more generics being used. Most of these were people with chronic conditions that are amenable to the generic meds. And then the quality, which, most HEDIS measures are, did you get the test when you were supposed to get the test? This actually is, did the test improve or did it get controlled for that relevant disease? And we were very gratified that the percent with substantial improvement and actual control of their disease has dramatically improved, and compared to the Nevada baseline and to national PPO statistics, these are really very, very good. And the satisfaction is probably the most gratifying, is that the people love this because it says, the doc says, if you wanted an MD VIP concierge level service, you'd probably be paying $2,500 or $3,000 a year, and your employer is making this available to you, and it's also connected to the rest of the system. Most of those concierge practices are not connected to anything else that's going on with the life of the patient. So it is possible to transform health. I believe for sure that this can really happen. I'm seeing it happen. It can be done in multiple settings, not just smaller self-insured employers. It can be large union health plans. It can be in populations where they are heavy-duty, very lot of high-risk practice, and like electrical workers and some of these kinds of settings. It works in people that are mostly call center workers that are sitting, and it is changing their obesity rates, et cetera. We don't have thousands and thousands of deployments everywhere, but for me, with the career that I've had in medical management part of my life, this is the most gratifying single program that I've done that, as far as sustained behavior impacts and change. So I really believe that there are options for us. The question is, what are we going to do about it? Are we ready to actually take these steps? Are we ready? Is the reason that we would be ready to change because we're fearful that bad things are going to only get worse and worse? Is it because we see that there is opportunity that we could make things a lot better? We have pessimists, we have optimists, we have those that are, you have various cultures as to what might stimulate you to say, I'm going to do something. I can do something, I will do something. The question is, what is your response going to be? So really, what are the next steps? Why wait? We know all that we need to know. We just have to have the will to make it happen. Thank you all very much.